Myself Dr. Dipti. I'm from Mumbai. I'm an obstetrician and gynecologist consultant. Okay, all the way from Mumbai to teach you over here. So please give just a little attention over here. Okay, so you must be knowing the pattern of your exam, because I don't know much about your pattern, which are the how much marks you are having for obstetrics and gynecology. How much marks are there for obstetric and gynecology? How much? 100 each? No, not for the theory. This is for the MCQ. For the MCQs you don't know. Fine, no problem. But this is the most scoring subject, I should say, rather than from physio or biochemistry or other subjects are there, because these things are not changing from years to years. It is the same, it is constant everywhere. Okay, whatever this is there. In India, what is there, we have to focus on that rather than the UK or the US practice what they are doing. Now the main topics which are the scoring, I will just start with those topics. So everyone must be knowing about the fibroids. Yes, right? What are the fibroids? Uterus. I will start with that topic first. So what are the other names of fibroid? I want more interaction rather than just telling you everything, because everything is given in books. Nothing much I have to tell you extra, because everything is there. You just need to focus ki which question can come as an MCQ. You have to just focus on that thing. So just what are the other names of fibroid? Leiomyoma, another myoma, another myofibroma, okay, but not leiomyosarcoma. Leiomyosarcoma is a cancerous change. Then the most common site for the fibroid? No, not subserosal. Intramural is the most common site for fibroid. I will tell you all the sites of the fibroid, but out of that, intramural is the most common site for the fibroid. Okay. Third thing, about how many percent patient they have symptoms and they don't have symptoms. This is the third most commonly asked question. What they present with, this is the most common question. What are the incidences of fibroid? This is the question which is asked. Okay. About the myomectomy, they ask you questions. And what is the other changes, secondary changes which occurs in the fibroid? This is the most common questions asked in your MCQs about the fibroid. Okay. Just to start with fibroids, this is a localized benign smooth muscle tumor of the uterus. It is the most common benign tumor of a genital tract, female genital tract. Most common benign tumor of a female also, if it is come as, right? Third is, it is hormonal responsive. Mostly it is responsive to which hormone? Estrogen. It is estrogen dependent fibroid or benign tumor. Clinically, it is found in 25 to 30% of the reproductive age group. Mostly it is asymptomatic. If you do a sonography of 100 patients, out of that you will find that in 80 patients the fibroids are present, but they are not having any menorrhagia or any other complaints, no pain in abdomen, okay, no other symptoms they will have. So this is the most asymptomatic finding which is seen in fibroid. They are almost always multiple, that is not having. Whatever is in blue, that can come most as an MCQ pattern. So that's why it is highlighted in yellow color. The most common indication of hysterectomy are the fibroids, because they have most common complaint. They are most common benign tumor. Obviously, most common benign tumor will lead into most common indication for hysterectomy. These are most commonly in the intramural, which is also called as an interstitial type. These are the site where the fibroids can be. Can you see this? See, this is the most thing. The upper one, which is the intramural fibroid, it is the most common, which is seen in almost 60%, which is most common. Then comes the subserosa, where the fibroids are situated. If it is near the serosa, then it is subserosal. If it is near the mucous lining of the endometrium, then it is in submucosa. If it is in the intramural into the myometrium, that it is intramural. So depending upon the site of the fibroid, they have named it. So the percentage you can see, which is more common, is intramural. Then comes your subserosal fibroid, which is 20%. Then submucous fibroid, which is 15%, and this submucous fibroid, as it is near to the endometrial cavity, it will lead into most common as an menorrhagia complaint. Patient will have more complaint of menorrhagia. Then there can be pedunculated subserous fibroid. Another are cervical fibroids. Okay, cervical fibroid is not drawn, but it will be coming over the part of the cervix. So on the cervical fibroid, it can be on the anterior part of the cervix or it can be over the posterior part of the cervix. So then depending upon the site, now the cervical fibroid will have more common complaints of retention of urine because the bladder comes over there. So obviously it will be pressing over the bladder, indenting over the bladder. The common complaint will be retention of urine, it will be there rather than menorrhagia. So depending upon the site, you have to know that which fibroid it is. Rarely this fibroids, they progress to malignant changes. So that is called as leiomyosarcoma. The incidence of leiomyosarcoma is 0.29%, which is 0.2 to 0.5% in books it is given. So you can remember, right, it is very least likely to go into a malignant changes. And this is more commonly not present in a reproductive age group. This leiomyosarcoma changes that will be in the perimenopausal or a menopausal age group, and it will be a very rapidly growing fibroid. Okay, it will be very soft in consistency. Just like a fibroid, it is very hard in consistency. It will be growing over a period of 10 to 20 years. The patient might be having at the age of 22. But she might be complaining at the age of 35 having complaint of menorrhagia, because at that time it might be a very small and now had grown over a year of 10 years. But this leiomyosarcoma, which is a malignant one, it will grow very rapidly, very fast growth, and it will not in hard consistency, it will have a very soft consistency. So that is the main difference between a leiomyoma and a leiomyosarcoma. The submucous and intramural type of fibroid, definitely they will have menorrhagia, as I told you, because it is near to the endometrial cavity, leading into the shedding of the endometrium. So why menorrhagia is more common? Because the blood vessels which are there over the endometrium lining, it gets thrombosed and it gets into the ectasis of the blood occurs over there. The surface area of that endometrium also increases, so more leading into the menorrhagia. Got it? So that's why the more symptom, rather than a subserosal which is situated near the serosa, which is not having any attachment with the endometrium cavity. So then definitely that will not present as having menorrhagia. So the subserosal will not have much complaints of menorrhagia. It will be an submucous and intramural. Then the subserosal, obviously it is, as I showed you the picture, it can be a pedunculated one because it is near to the serosal level. So if it is protruding outside the uterus, then it will become having a peduncle along with that. So with that peduncle, more chances of having torsion of that fibroid because it is freely mobile in the abdomen. So it can lead into a torsion. So this pedunculated, it will be always a torsion present with what? It present with pain in abdomen, vomiting, nausea. These are the main symptoms if any torsion are there. Just like torsion of ovary, if it is there, the patient present with acute pain in abdomen, vomiting, loose motion, or sometimes it is nausea. That is the main picture. So this submucosal will lead into the acute pain and the torsion of the fibroid. So what is all these different three things which I have put? That is, I don't know it's there in your book or not. Intravenous leiomyomatosis. These are when these tubercles of the fibroid parts, if they are going into the veins, that is the uterine vein is the most common where it goes and it grows into the broad ligament part, then that is called as an intravenous leiomyomatosis. This they can ask you as an MCQ. Second is leiomyomatosis peritonealis disseminata. If you see the while doing an abdominal hysterectomy, I found that over the peritoneum there were the tubercles present, which was looking like a nodule part. So this fibroma which was there, it has disseminated into the peritoneum and had developed into a small nodularity, which was not a CA endometrium like, but it was a fibroid part which has grown into the peritoneum. Obviously the peritoneum, that the peritoneum surface or the omentum, it is having the most maximum blood supply over there. So that has developed into a leiomyomatosis peritonealis disseminata, which is a very rare this thing, but it can be seen in patient having fibroid. Then another is STUMP, that is smooth tumor of insignificant malignant potential. When we are calling it as a benign, when we see under a microscope, we get less than 5 of the mitotic figures per 10 high power filled. So then it is called as a benign. जो cells होते हैं count करते हैं microscope में. So then if it is less than 5, then it is called as a benign one. If it is the mitotic cells are there, mitotic cells से पता होगा, dysplastic cell, metaplastic cells और सब. So this, if it is more than 10 of the mitotic cells, then it is a malignant potential. So less than 5 is a benign, more than 5 is a malignant potential. But if it is something between, you get between a 5 and the 9 mitotic cells per per 10 high powers filled, then it is called as STUMP. That is smooth tumor of insignificant malignant potential. Don't get so much confused, you know, everything is in book if you read and this thing. Now it's your final year only. But this STUMP, it is 5 to 9 okay, mitotic cells are there. So this is again the picture. See, there you can see a cervical fibroid is, can you show, can you see the cervical fibroids are there, and another is an intraligamentous fibroid also you can see over there. Okay, there are two things. Another, there is called as a broad ligament fibroid. There is a true broad ligament fibroid and another is a false broad ligament fibroid. So broad ligament fibroid, now everyone knows about the anatomy of uterus. The uterus, okay, the fallopian tubes, round ligament, and there is a broad ligament which is attached to the lateral pelvic wall. If this fibroid is growing into the lateral part of the uterus and it is growing into the broad ligament, obviously there is a space where it will grow. So if it is growing into the broad ligament from the uterus part, so then it is a false broad ligament because it is not arising from a broad ligament. It is arising from uterus. That's why it is called as a false broad ligament. And over here the significant will be the ureter will be lateral. It will go lateral. And over here in the false broad ligament, the fibroid, it will be growing from the broad ligament. So that is a true broad ligament. And the ureter, it will be coming obviously to the medial to this. Okay, lateral to the uterus but medial to the fibroid. So that is the true broad ligament fibroid and a false or a pseudo broad ligament fibroid. Again the same. These are the, you get these pictures in your exams also, in MCQ exams like that. It's there in, okay, Maharashtra, so that's why I thought that. So this is the normal and the, you can see, the world-like appearance you can see over there. What are the secondary changes which take? Don't look at the slides now. What are the secondary changes? Common secondary change in fibroid? Come on. No one is there. You can speak loudly. Hyaline degeneration. The most common is hyaline degeneration. Everyone has read this in second year. Patho, Robbins. Okay. Then comes another degeneration. The most common degeneration in pregnancy is red degeneration. The treatment for red degeneration? Treatment. You will remove that fibroid because obviously it is causing so much of pain. Na? No, you don't have to remove the fibroid. Because the red degeneration, the main treatment for red degeneration is just give proper rest to the female, analgesic, okay, and antibiotic. That's it. Nothing else we do. If you want to do any surgery on female, so on which trimester you do it? Just a random question. Second trimester, that is sure. Okay. So this is a painful interstitial hemorrhage often with the pregnancy. The second name of red degeneration is Carnier's degeneration. It is also called as Carnier's degeneration. There is one more degeneration which is calcaneus degeneration is also there. So just don't get confused with these two different things. It is Carnier's degeneration because always you will get confused with B, C or like the two things which are more common. So that's why. Cystic degeneration, it is seen most common in perimenopausal or menopausal females. Okay, calcaneus degeneration is there, another. So these are the pictures where showing the hyaline degeneration, the black spot which you can see over there. Uterine location of the leiomyoma, as I have told, submucous, it is just below the endometrium, tend to bleed. Intramural within the uterine wall, subserosa just below the serosa, cervix in the cervix. There is one more, it's a parasitic fibroid. Parasite, it is developing from the uterus, it is wandering in the abdomen, it getting the blood supply from the omentum, intestine and everyone. That is called as parasite. The fibroid obtain the blood supply from other organs. Interligamentous, the fibroid grows largely laterally into the broad ligament. That is nothing but a false broad ligament and a true broad ligament. That is interligamentous. Most of the patient, as I told you, they are asymptomatic. They don't present with any complaint. It is just present in them. It is mostly an USG or an incidental diagnosis they have, which is found in more than 50% of the cases. Another symptoms and signs they will have will be bleeding linked to the sign of anemia. Then 1/3 of the patient will present with bleeding, that is there. Abnormal blood supply, pressure, ulceration and abnormal endometrial covering, that leads into menorrhagia, which I told you is a thrombosis, then large surface area and more blood supply is there over that point. That's it. The pain is because of the secondary dysmenorrhea. This fibroids, they leads into both types of dysmenorrhea. What are the two types of dysmenorrhea? Spasmodic and yeah, don't look at the book. Yeah, but right. There are two types of dysmenorrhea. One is spasmodic and congestive, and this fibroid leads to both type of dysmenorrhea. Okay, because congestive, definitely more blood supply is there to the fibroid, and it is spasmodic, it pains. There is a contraction in the uterus, so definitely it has to be spasmodic. Then the pressure symptoms are seen in this cervical fibroid or other any anterior wall fibroid, which will lead into the compression over the bladder, leading into the retention of urine, leading into dysuria, more of UTI. These are all sequelae of one and the other thing. If it is compressing over the posterior part, leading into constipation. Simple. And infertility, should not forget this. Infertility is maximum patient of infertility can present with fibroid, and if it is present mostly on which area? Fundal pe bhi cornual part pe, if it is there, which is obstructing into the fallopian tube opening, which is restricting the motility of the fallopian tube, mobility of the fallopian tube, so that the sperm will not able to transmit from there. Then that is the most common thing is seen in infertility patient. Definitely diagnosis, always examination come first. Doing a bimanual examination, per abdomen examination is there. Another is the gold standard is always USG, because USG is easily available, easily in every hospital you get ultrasonography. So that is the ultrasound, that is USG is the gold standard for the diagnosis. If not, then if it is any difficulty, whether if it is a lateral or a broad ligament fibroid, one is not able to judge it whether it is a broad ligament or it is an ovarian pathology, because obviously the ovaries also comes in that part. So if one is not able, then it is an MRI which comes for this thing. So it may visualize by X-ray, MRI, CT scan, HSD and hysteroscopy, but no one does that nowadays, truly speaking. It is only USG, X-ray no one does it. So it is USG and another is an MRI which is there. Pap smear, EEG, that is endometrial biopsy, hysteroscopy and DNC can be done just to rule out malignancy. Any patient, like if it is coming at the age of 42 years, patient comes to me with complaint of menorrhagia. Okay, I just do her per vaginal exam, bimanual examination, and I found that it is a 12-week size 12-week size uterus is there. Not necessary ki always I will get a fibroid in that thing. 12-week size uterus can also with menorrhagia can also have two type of diagnosis. One is adenomyosis. Okay, and another is fibroid, because adenomyosis is what? Endometrium lining, it is growing into the myometrium, where the uterus size grows till the 14-week size of uterus. It is not much more than that. That's why I mentioned about if it is a 12-week. Then definitely if on sonography, if I get a fibroid, then also it's okay. But I just have to, it's a age of 42, which is not near to menopause, but it is okay, near to a perimenopause, not in a reproductive age group also. So just one dilatation and curettage it is required to undergo any hysterectomy. It should not be like that ki after doing an hysterectomy, the specimen in histopath report, it comes out to be a CA endometrium of stage 3 along with the fibroid. So the whole treatment then changes. Then you don't want to reopen that patient for removing the ovaries also. In CA endometrium, you have to remove ovaries. So that's why the main thing is that any patient presenting with menorrhagia or this thing, you have to do a dilatation and curettage just to find out whether it is not a CA endometrium, it is a normal endometrium, and then you can proceed with myomectomy or hysterectomy, whatever is required for that patient. This is the MRI which shows fibroid. This is the USG which is showing fibroid. It is a very uniform which is seen in the uterus part. Okay. If it would have been over here or here, something over the ovaries, it could be having a simple cyst because it is not having any echoes or anything. These are the picture of a fibroid. This is what? It's not that clear. This is hysteroscopic vision of intracavitary myomas are seen. If it is coming into, just like if it is submucosal fibroid, so rather than opening an abdomen and removing that uterus, going into the through the cavity of uterus, it is difficult to remove it. You can go through the from below, per vaginally you can put an hysteroscope and then you can visualize that fibroid, and then you can easily remove it with the help of resector scopes are there. You can see this the ring shape, that is a resector scope loop. The current flows through that, and whatever the myoma is there, you can cut through that myoma. So it comes in pieces form. Okay. I just treatment of fibroid. Don't read that slide. If it is asymptomatic patient coming to you with the 8 or 10 week size of fibroid, always the size of uterus it is tell in weeks form. Okay, if it is a 8 weeks or 10 week size. If the patient is coming, she is having an incidental finding, she did USG for some other thing and then she is having, then you just have to counsel the patient that she doesn't require any hysterectomy for such kind of fibroids. She can wait and watch. She can have proper follow-up with ultrasound, or she should look for the symptoms if it is any, and then they can proceed. If the fibroid is growing more than 12 to 14 week size, then definitely patient may require surgery. So it is like even if it is an asymptomatic fibroids of more than 12 to 14 weeks, that requires surgery. Okay. So it is 12 to 14 week size asymptomatic fibroids which requires surgery. And as it is an hormonally sensitive tumor, it generally gets shrink after menopause. Okay. So what are the medication which we can give to cause a medical menopause, which will shrink this fibroid, which are called as medical oophorectomy, drugs causing medical oophorectomy, or drug causing medical menopause. Sorry. Aromatase inhibitor. Before starting with aromatase inhibitor, something else you would like to give, because aromatase inhibitor will cause GnRH agonist. You will give. What are the drugs of names of GnRH agonist analogs? No problem. You are obviously final year students. Then also, okay. Most commonly used drug, Liprolide. Leuprolide depot is the most commonly used drug, which is available at 11.75 milligram, then 3.75. It is given at the if it is 3 point, then it is given at the interval of 28 days. Okay, that leads into medical menopause. Okay, aromatase inhibitor are there, but then what is the name of aromatase inhibitor? Danazone. But then the main side effect is it produces androgen, then more chances of having acne, hirsutism to the patient. So that side effect is there. When we are giving GnRH analog or the analog, we are not giving it much, for a longer time. Even that we are giving maximum we can give till 6 months. Okay, after that we don't give it because it causes yeah, obviously it is a medical postmenopausal drug, so it will cause postmenopausal symptoms. It causes hypoestrogen. So that's why we have to supplement then patient with estrogen supplements, right? So this GnRH analog, how it acts, the mechanism. First it increases the FSH-LH ratio. Then afterwards it has a negative feedback effect which acts on the ovaries, and it leads into the decreased estrogen level. So first it increases the level and then it decreases the level of this. That is a negative feedback mechanism is there. So that is there. Aromatase inhibitor is there, but it is not generally used. But yes, it is there as a name you should know. What is a newer drug which has come up for this thing? One newer drug has come which is called as a asopirinil. ASOPIRNIL. I have given in some slide, I think that asoprisinil. It's a selective estrogen receptor modulator, which has just come out in market. It is not FDA approved as much in India, but it is under trial, and they said that it is a selective estrogen. It is the first selective estrogen receptor modulator, asoprisinil. Okay, so this decreases the estrogen level. So let's see how much it is. The other name for asoprisinil is uripristal acetate. Okay, that will I will show you. Then pregnancy is usually uncomplicated, but yes, we get patients. I get almost two patients. I had two patients of red degeneration during pregnancy last month, and those have such a tremendous pain, just like you feel like you have to remove that fibroid. And patient they say that, but only the bed rest and analgesic those help to the patient. Some fibroid grow to the size during the pregnancy. Bed rest narcotics are indicated for the pain and the with red degeneration. Then treatment, it is as I told you, when the tumor size grows more than 12 to 14 week size, then the treatment is required for those patients. As the hematocrit fall, tumor compresses to the adjacent structure, and obviously if it is hampering the social life, having lot of menorrhagia to the patient and this thing. When the use of GnRH is there, sorry I didn't ask that question, when you should give GnRH to the patient? When the hemoglobin is too less, patient is unfit for surgery, when you want to postpone surgery for a long time, if the patient is hypertensive, diabetes, she is having asthma, everything, she is not getting fitness for surgery, but she is having menorrhagia, she is having complaint, so you just can't say that okay, you sit at home. So then at that time, by that time you will give GnRH to that patient. Another, if the hemoglobin is too less, then you just want to postpone surgery for some other reason. Okay, then fourth thing, if the patient is near to perimenopausal age, because you know that after menopause this fibroids will get shrink. So if you want that you want to postpone the surgery, in the perimenopausal period, then you can just tell patient okay, just try for 6 months. If it is there, otherwise we can remove the uterus. That is there. GnRH agonist for given for 6 months, as I said, that is an MCQ. Myomectomy. Myomectomy is another MCQ. What are the principles of myomectomy? What is myomectomy? Myomectomy, removal of fibroid. Yes, it can be done through laparoscopic, through laparotomy. Laparotomy is opening of abdomen. Laparoscopy is through laparoscope. Hysteroscopically you can remove it, and another vaginally. This is the main thing. Okay, if there is a vaginally, you can see a pedunculated fibroid is seen. So you are not going to put a laparoscope and going to remove it. Obviously, you have to remove it vaginally. So vaginally also you can do a myomectomy. Now this myomectomy, principles of myomectomy, whenever we are doing myomectomy for a patient, obviously the patient will require to conserve that uterus. At that time only she will be going for a myomectomy procedure, otherwise not, right? In that case, if it is for an infertility patient, then we have to see whether the other causes of infertility should be ruled out. It should not be like if she's having a genital cox with a fibroid, and where this removing of the fibroid is going to help her fertility. Obviously, the genital cox is there, which is hampering her motility of the fallopian tubes and the ovarian function. Or if it is a premature ovarian failure symptom, patient is having with fibroid and you will remove fibroid. So the other causes of the infertility should be ruled out. Then the semen analysis should be done whether the male part of fertility should also be ruled out, whether the patient can conceive after doing this myomectomy or she is going to require a IVF or something other thing, right? So that is there, that should be ruled out. These are the two principles. Then third principle, through one incision you have to remove as much as myoma it is possible, just making a tunnel and removing all myomas, taking a vertical incision or whatever over the fibroid. If it is a fundal fibroid, then which incision is taken over the myoma? It is a transverse incision which is taken over the myoma if it is a fundal fibroid, because the fallopian tubes are there. If you take a vertical incision, it will come nearby and there will be the kinking of the fallopian tubes. So that's why we take a transverse incision, so that the anatomy will be maintained, it will not get distorted. Okay. If it is a cervical fibroid, you can take a vertical incision over there, because laterally ureters are there, so that's why you don't want to get extend over there. So you can remove that myoma, you can extend your incision. So depending upon what structures are there near about, you have to see, and then you have to plan for the incision over the myomas. So that is that. Then proper suturing should be there, proper hemostasis should be there. Even if the hemostasis is not proper, then it can lead into infection and rupture in pregnancy, next pregnancy. Then surgical removal of fibroids in infertility. Myomectomy is for women who desire to retain their uterus for childbirth. Not even that, not for the childbirth also. If patient is there, like belong to Ambani family or some other family who don't want to remove her uterus and she just want to this thing. So that is not the thing for infertility point of. It depend upon the will of patient. It doesn't depend upon the age of patient. Yes, you can counsel the patient that at the age of 48, better to remove her uterus rather than go for myomectomy, right? So this is also depend upon the will of patient what she wants. If she wants myomectomy, you just can't remove her uterus and give her in that. About 1/3 of the fibroid they recover after having myomectomy also, because they have the potential of developing again and again and again. This is vaginal procedure where vaginal myomectomy is done. Generally a pedunculated, just like I told you, if it is a cervical fibroid which is protruding out of the cervix. So then you just have to hold it with an Alice forceps and you just have to twist on it. That's it. That is the cervical, because they don't bleed much. If it is a mucosal polyp which is coming, because most of this time this cervical fibroid, protruding cervical fibroid or a polyp, it get confused with what? Other DD for this polyps are? Say anything, no problem. At least I will this thing. Uterine inversion. Okay, these are very difficult to distinguish between a polyp and a uterine inversion. Fibroid polyp specifically, because it is hard in consistency. That's why like the uterus. So just you have to distinguish. By putting a sound, you see that whether the pedicellate is felt or not, the cervix is there or not, that way. So that is, you have to distinguish between those two things. These are the pictures of laparoscopic myomectomy. Hysteroscopic myomectomy, again with that resectoscope, the myoma is removed. Hysterectomy, Obviously, if the patient has completed childbearing, she doesn't want that uterus to be retained. Even she is 40 years of age, max to max at the age of 38, even she doesn't want to retain her uterus, you can remove it. It's not like that. At 38 she is reproductive. If she says that no, I have completed, I am having 2 children. She is 38-year-old. She wants to remove, you can remove it. It's not that. Definitive treatment for fibroid is obviously hysterectomy. Then if the pregnancies are there with the fibroid, so then what are the changes or what are the complications which can occur? Obviously fibroids are there, so it can lead into bleeding inside the placenta, because the placental insertion will be not uniformly placed, so there it can lead into abruption. First trimester bleeding can occur because of that. Dysfunctional labor will be there, the contraction will be not coming at a proper interval, so it leads into a dysfunctional labor. The space will be less for the baby to fit inside, and then can lead into a malpresentation or breech presentation. And if it is compressing over the presenting part, that is the lower part, which is obstructing the labor, definitely chances of C-section, cesarean will be more in those cases. And of course right degeneration too is there only. This is the cut section of uterus which showing fibroid inside, you can see. What is embolization and contraindication for embolization? Uterine artery, it is uterine artery embolization, okay. So what are the things where we put catheter, and in which case you put catheter, like uterine, for uterine artery embolization, and what are the contraindication for this thing? This is a newer thing which is there, it's not newer, but uterine artery embolization, we put catheter into the femoral artery, okay, which goes through femoral artery into the, come on guys, anterior branch of internal iliac artery, right? That gives major, from there anterior branch of internal iliac artery, it gives the uterine branch, okay. So over there the uterine branch, it gives the maximum blood supply to the uterus. So this embolization can be done when you are thinking that the fibroid, it is too big, that there will be a torrential bleeding in a patient while doing a surgery, then this embolization can be done. Prior to surgery it can be done. If you want to avoid surgery for that patient, then also the embolization can be done, because it will give less supply to the fibroid and it will shrink, that fibroid will get shrink in size, because obviously the blood supply is not going into that fibroid. So this polyvinyl particles are there which are injected through the femoral artery. The catheter, it is placed under USG guided or guided this thing, and then just before one, under guidance only, USG guidance only, they just push almost 2 ml of the polyvinyl alcohol or what the solution is there into the femoral artery, they push it, right. So because of this embolization, the blood supply to the uterus gets less, it gets shrink. Chances of pregnancy or chances of rupture uterus in next pregnancy will be high if patient wants to conceive. Obviously when patient want to preserve the uterus, then only they will undergo for this embolization. If patient want to remove the uterus, then they will like to obviously hysterectomy. So for this embolization, it is contraindicated if the patient is having pelvic inflammatory diseases, PID, then this should not be done. Then if the patient wants pregnancy or patient is pregnant, then they should not do this, because as I told you, chances of rupture will be high, pregnancy won't be there, right. And any bleeding complications are there to the patient, bleeding diathesis, okay, hemoglobinopathies or something are there, then that patient should not be there, because the chances of bleeding will be more while putting this catheter and this thing. So this is about the embolization. You can see that catheter, it is going into the uterine artery part, and then so whatever the blood supply is there, it is getting blocked by that thing. Okay. These are the placenta with fibroids. That's it. That is inversion. It is more common in fundal fibroid. Pseudo mixed syndrome and mixed syndrome you must have heard. What is mixed syndrome? What is mixed syndrome? hydrothorax, ascites, obviously ovarian pathology, benign ovarian pathology, something must be there. So that is right-sided pleural effusion, ascites and benign ovarian pathology. And this pseudo-mixed syndrome can be seen with the fibroid, that is mixed syndrome which is there. And this pseudo-mixed syndrome it is seen with the fibroid which is in the subserosal layer. Then inversion, it is more common in the fundal fibroid. What is lantern on dome on St. Paul? Dash fibroid is called as. Don't look in your books, huh? It must be there, but I don't know. Lantern on dome on St. Paul. That is a cervical fibroid because it gives an appearance. The cervix is there, the fibroid, and it is just situated like a lantern. So lantern on the dome. It is cervical fibroid is called as that. Pseudocervical fibroid, as I told you, the fibroid polyp which is coming from the cervix part. So this can give a picture of a pseudocervical fibroid. Okay. Calcaneus degeneration, that we have done. Right. And remember, calcification begins from the periphery and the degeneration occurs from the center because obviously blood supply is more over there. So degeneration will start in the center. DC and CP. This is not going आगे. Okay, fine. I don't know. इतना ही था? Okay, fine. What is HIFU? HIFU? High intensity focused ultrasound. Okay. Same as that, there is MRSFU also. That is MRI guided. Now the other newer techniques are there. Just like uterine artery embolization, there is something called as HIFU is there. In this HIFU, patient if is having fibroid, it is laid in a prone position over the MRI machine or over the, you can say it as an MRI machine. And whatever the rays are there which are transmitting from that coil, it will act on that fibroid and it will lead into the shrinkage of the fibroid. So that is in HIFU and MRSFU is there. So this is for the patient obviously who wants to preserve their uterus and they don't want to remove, and the chances of the pregnancy definitely will be low. Again, the same thing is there as that is there. I have put a picture of that, but it is okay, yeah. Okay, pregnancy rate after mammectomy is almost 40 to 60%. Recurrence rate, as I said, it is 30 to 50%. Just some percentage are there, those things. Then 20 to 25% after mammectomy comes for hysterectomy. Obviously, the recurrence is there. Contraindication for lap mammectomy, laparoscopic mammectomy. If the uterus size is more, if it is more than 16 week size, obviously, because where you put the port, the primary port it is put intra-umbilical or infra-umbilical? Intra-umbilical it is, okay. It is at the groove where it is. We don't put infra, we put intra-umbilical. So, while putting a primary port which is 10 mm, and obviously if the uterus is so big, it will directly go and hit into that uterus. Some space should be there. So, that's why it is uterus size more than 16 weeks. If it is there, we don't. If myoma is more than 15 centimeter, obviously if the myoma is big, the uterus size has to be big. So, then definitely. Then, that are the two contraindication for lap mammectomy. But if the patient, if the surgeon is very expert, like a very expert laparoscopic, obviously he can remove any kind of, any size of. But for your exam point of view, MCQ point of view, these two things you have to just remember. Then I told you about the aciprisnil, which is a selective progesterone receptor modulator. Okay, that is a drug. And why this 1867 I have written? What mifepristone other name is? RU486. What is that RU486? In the company which have manufactured that mifepristone, that was that number of drug, 486 number of drug which they have manufactured. That's why the name was mifepristone RU486. So this is something like that only. 1867 is the name of drug what they have given. MRFUS, I told you, it is a magnetic resonance imaging focus ultrasound. This thing you can see this, the fibroid where the energy, the focus ultrasound energy which is near the field, that is an ultrasound transducer. So it is directly hitting over that fibroid. Okay, definitely it is doesn't require only one setting. The patient has to come again and again for the frequent settings for this thing, because at the one time only it will not shrink the cells of the fibroid. Which clamp it is? This is Boney's myomectomy clamp. Okay. See, there are two openings anteriorly and two rings are there. Right? So this is while doing a myomectomy, we apply this clamp, that is called as a Boney's myomectomy clamp, so that the blood supply to the uterus will get less after applying this clamp. The other thing which you can do to while doing a myomectomy, myoma it is very vascular. So while to just decrease the blood supply of that myoma, what do? Sorry? Yes. Which drug is used? No. While doing surgery, GnRH we use it before surgery if we want to postpone it. So while performing myomectomy, we can use vasopressin. Vasopressin belongs to which drug group? ADH, na? Shay? I think it is ADH group. Okay. So this vasopressin we just inject over the myoma, which will decrease the blood supply of that myoma. Another, you can put a rubber catheter. Okay. Then you can ligate the uterine arteries. That is one more thing. And this clamp. When applying this clamp, you have to release this clamp every 10 to 15 minutes. Why? Because after applying a clamp, it releases histamines and other prostaglandins into the blood, right? So that's why we have to release this clamp every 10 minutes, after every 10 minutes while performing surgery. So this is that clamp. They can ask you in exam Q which clamp it is. So this is Boney's myomectomy clamp. Any queries regarding fibroid? The maximum things are there in your book. You just have to read them and you have to understand them. You should know what the examiner wants to ask from you. You have to read your question very nicely, very carefully, what they have written in that. Even if you miss one word out of that, then your answer changes. Your whole answer will just change. So this is just a thing of your 3 hours, your concentration, okay, and your why he's laughing. Everything, your concentration should be much more, presence of mind should be much more at that time. So okay, fine. Any doubt with fibroid? If not, then I will move to other topic. Any doubt? No doubts. So this means you have understood this topic very nicely, or you have not understood it. Okay, fine, no problem.